Thank you, Karan, to have me here, and it's a privilege to be among the stalwarts in the field of ophthalmology. My topic for today is diabetic retinopathy and when to intervene into them. So,
Click with the mouse on your screen. Yeah, it's good.
Is it better now? Yeah. So to start with, it is estimated that by the year of 2040, we'll have around 60 crore people in worldwide will have diabetes, of which 40 to 50 crore people would be actually in low and middle income countries like ours. We know that diabetic eye disease is the most common microvascular complication of diabetes. Patients who actually have PDR or diabetic macular edema, if they are not treated well, they would actually end up with blindness. And it is actually postulated, or it is actually present, that 1 in 3 patients who have diabetes, they actually have diabetic retinopathy. And of which 1 in 10 of the patients with diabetic retinopathy will have the blinding disease, that is PDR or a diabetic macular edema. So just a perspective, if for a timely intervention of for timely intervention with patients with PDR and diabetic macular edema, we can actually prevent blindness in up to 98% of the patients. And the pillars would be to make patients aware about it, to do a good screening, and then to refer a patient in timely intervention. We all know that diabetic retinopathy basically happens because of longer duration of diabetes mellitus and poor systemic control of sugars, blood pressure, and blood lipids. If we can control all this, we can definitely prevent diabetic retinopathy progression. But then again, still the patient can develop diabetic retinopathy. What happens is, most of the times we have patients, we tell them to have a good control of sugars, pressures, and lipids. And they say that we will not develop diabetic retinopathy, but that is not true. You can actually prevent the progression of diabetic retinopathy, but the patients may develop diabetic retinopathy in the future. So we have patients where we have done a very good cataract surgery, and 5 years, 10 years down the line, they actually have diabetic retinopathy. So we have to call those patients yearly for examination to rule out if they have diabetic retinopathy or not. Secondly, one thing is most important, the blinding disease, the PDR and the DME, the patients may actually not experience any visual symptom loss. So we have to tell them that this is a condition which requires intervention lately, even if you don't have visual complaints. Now, before going into these screening of these patients, we should know what we are looking at. So the classification is there. There is basically the non-proliferative diabetic retinopathy and the proliferative diabetic retinopathy. The non-proliferative being there is no presence of neovascularization, and then we have in that mild, moderate, and severe. Mild is basically there is presence of only microaneurysms. The moderate ones, which we can see in the lower column, where you see presence of microaneurysms along with hard exudates, hemorrhages, or cottonwool spots. A severe NPDR is slightly confused with PDR, and there is a mixture of like either ways. So a severe NPDR would be presence of moderate NPDR, and there would be presence of hemorrhages in all the quadrants. There would be definite venous bleeding. That is the 4-to-1 rule which we are talking about. So intraretinal hemorrhages, venous bleeding, and presence of edema. So if you have these, that is severe NPDR. A PDR is definitely a patient when the patient has neovascularization. You have to look in for neovascularization at the disc or elsewhere. You have to look in for these pre-retinal hemorrhages. A lot of times we actually end up with patients who have a hemorrhage which looks like a dot and blot hemorrhage. Normally those dot and blot hemorrhages are in the intraretinal space. So if you see a blot hemorrhage or a very big hemorrhage which is obscuring a major vessel, that is a PDR and not a severe NPDR. Because these patients may end up late in your for referral, and they may actually end up with more complications. Now, the newer classification basically talks about, earlier we used to have the ETDRS classification now, but along with that, now you have the diabetic macular edema classification, where basically they talk about macular edema which is present center involving and non-center involving. Non-center involving is basically there is presence of retinal thickening of the macula, which is not involving the central subfield zone, that is the first 1 millimeter of the fovea. Similarly, a center involving DME will be having presence of retinal thickness involving the central subfield zone. Now, once you know what diabetic, if you are able to classify a diabetic retinopathy, then it comes the screening part of it. For screening, you have to understand that it is very cost effective, and one needs to do a vision of the patient with either pinhole or refraction, and one should do a dilated pupil examination. You can take up a photo which can be sent to your retina colleagues or maybe to your peripheral center accordingly, and these can be done at CAMS, vision centers, and clinics. This is a rough algorithm to see and when to refer a patient. So a patient who has a very good vision of better than 612 and he has no diabetic retinopathy, we can call the patients routinely 1 year and so on. If the patient has a poorer vision of worse than 612, and if there is presence of more mild to moderate Npdr, you have to send the patient for further evaluation. But it is not urgent. That is up till 3 months you can send these patients. But if the patient has severe Npdr, diabetic macular edema, or a PDR, it requires an urgent referral. So here you can see another, when do you re-examine these sort of patients? So a moderate Npdr would be roughly 6 to 12 months. A severe Npdr would be less than 3 months. A PDR would be less than 1 month. And all these patients are to be referred. A patient who has diabetic macular edema, if it is involving the center involving, then the follow-ups are 1 month, and for these patients also urgent referral is required. So once a patient has been referred to an ophthalmologist or retinologist, these are the things one should look into apart from visual acuity, that is intraocular pressure, to a gonio, to rule out any neovascularization, slit lamp microscopy, and fundus examination. Along with that, one should do a fundus photography and an OCT to see for diabetic macular edema. FFA is not a compulsion, but can be done in case of doubts or if you have to rule out any macular non-perfusion. So these patients are followed up again for severe Npdr less than 3 months, for a PDR less than 1 month, and you have to consider PRP in these sort of patients. And if you have a center involving DME, you have to do either lasers or anti-VEGFs, and the follow-ups are 1 to 3 months. Now coming to the management, if a patient has a PDR, you definitely know the standard treatment is PRP as of now. There are some conditions of severe NPDR which actually require PRP, that is poor compliance. The patient is coming from very far off, or the patient is not going to come back for follow-up. Those are the patients we should do lasers. If you have a patient with severe NPDR and if there is good view, having a cataract, better to do a PRP than take up for surgery for cataract. Or a pregnant female who is actually having a severe NPDR, you can actually do a laser. And status of the other eye, if the patient is one-eyed patient of the other eye had a PDR, better to do a PRP in these sort of patients, because severe NPDR actually goes into PDR 50% of the times by 1 year. So these are some indications of it. Now, treating of diabetic macular edema, one should know when to treat them. If you have to assess both the staging of diabetic retinopathy and whether the center is involved or not. So if you have a mild to moderate diabetic retinopathy, not center involving, one can observe or one can do lasers. I prefer to observe if the patient can come for good follow-ups. If in case the patient is hesitant, you can actually do some lasers. For patients with moderate to severe NPDR, and if it involves a macular edema, the center involving DMA is present. If the vision is good enough, one can observe or one can laser. I prefer observing those patients. If it is actually macular threatening, one can counsel for injection, but one has to explain about end off. But if the vision is poorer, better to go for anti-VEGF therapy. Now coming to the anti-VEGF therapy in patients with DME, according to drcr.net study, they say that at least 6 injections are required monthly. But in our setup, it is quite difficult. So at least by 2 to 3, I kind of give 3 loading dose or 4 loading dose of injections. I have to counsel the patient that this edema is not acute. It has been developing for many months. So you would require 3 to 4 injections, and depending upon it, you have to assess the patient after the loading dose. And you have to see whether the DME is improving or not. If it is improving, one can counsel for more injection. If it is not, one can switch from anti-VEGF injections to implants or do a focal lasers, and so on. You can follow up. So patients management of diabetes in special circumstances, we have touched upon pregnancy. But so if a patient is having if the patient is having diabetes and she wants to plan a pregnancy, a screening should be done for diabetic retinopathy. A patient who has a pre-existing diabetes and is pregnant, you have to do a screening for diabetic retinopathy at the first antenatal visit. If there is no DR, then you have to do a screening at 28 weeks. If there is DR, you have to do screening at 16 to 20 weeks and laser accordingly. No anti-VEGFs are recommended. And finally, for cataracts, then it's might if you have the a severe or a PR, a severe Npdr or a severe Npdr or a PDR, you better treat the retina first and then take it for cataract surgery. If there is no fundus view, do a cataract surgery and then followed by retina evaluation. And if you are able to access OCT and if the amount of cataract is severe, you can give an injection before or at the time of cataract surgery and then reassess in retina clinic after a month. So to conclude, patient education is most important in these sort of conditions. One has to explain to them that timely intervention is required, even with good vision and no ocular symptoms. One has to have strict systemic control, and patients who do not respond to your therapy or if there is a failure of treatment, vision rehabilitation is to be done. So I can conclude with, in the field of observation, chance favors only those minds which are prepared. Thank you.